Let's go ahead and get started today. So this is the third session for this quarter for health and homelessness. Thank you for coming, even on this gorgeous day. So a couple things before I introduce the speaker. There's a new street medicine project that is being started by a couple school of medicine students that I spoke with, and they are looking for student leadership in the School of Dentistry. Donald Shee, who we all know, is the faculty that has signed on to be part of this project, but they're still looking for student leadership. So if you're interested, I've talked to a few students about it, but they're definitely looking for involvement. And I have their contact information down there, and I can get you in touch with anyone, or I can get you in touch with them if you're interested. So if you volunteered already, or you plan on it, make sure that you log your hours. So the requirement is 6 hours of community outreach per quarter. Go to healthandhomelessness.com. There'll be a little outreach tab on the left, and then once you go to that website, you can log your hours. Don't forget to sign in and do the speaker evaluations, and I'll let Dr. Gandera talk for a few seconds just about another community outreach opportunity.
Okay, and Ian, thanks for being here. Yeah, it's so pretty outside, so thank you for coming, and I think we have a great presenter who's going to come up here shortly. And I just want to make a comment about the evaluations and feedback. It's really, really helpful. Just on your outreach, when you go on the outreach, when we have speakers, the class, how it's set up, all of it. Because, you know, we just started this a year ago, and it's been very successful. And I think we all are getting much more knowledgeable about how people get homeless, what are the things that, you know, what are people dealing with. And also the numbers that are affecting people, whether it's domestic violence or substance dependence or suicide. And, you know, there's a lot of hurting people out there, and there's a thin line between, you know, anybody being okay and not okay. You know, we kind of have to take care of each other. And we, especially as healthcare providers, have a lot that we can offer, and that makes our whole community better. So again, I thank all you guys who have been in the class this quarter new and all along for caring to learn more about how to be as full a provider as we can. I wanted, David alluded to one of our newest outreach, and we didn't get photos up here for you, but Heidi Johnson is was a student lead on that, and you may have heard us refer to this before, that this was a vision of Tyler Rumpel and Luis Acevedo when they were AmeriCorps members, and also Eric Nelson contributed to this as an AmeriCorps member, and that was our inaugural Skagit Valley outreach. And we were able to use these beautiful facility of the Northwest Career and Technical Academy. And some of the first years came, so thank you. And what we saw, that by having the space and having the community there, who were registering patients and kind of helping with things, that we can expand our services, not only having more space, but kind of what we do. We saw 18 patients there. Of the 18 patients, a third of them had diabetes. So we kind of took an informal survey, and about a quarter of them had hypertension. So, and this was the first and second years who were picking this up and getting them ready and primed, so when they came up with the extractions, that data was gathered. But we were telling patients, your pressure is high, and then they go back to Free Harbor, where there are physicians who are volunteer physicians who can help them. So we can actually put to practice what we've been learning as far as interprofessional services. So that's kind of exciting. There's space. There's space to eat, put out nice food, you know, that kind of stuff too. So anyway, so Dr. Eastgard is here, and there is also these pamphlets that she brought. So please feel free to get these on your way out. I'm sure she'll refer more to them.
Without further ado, let's introduce Sue Eastgard, the Director of Training from Forefront, and also in the school social work.
Do you need?
Okay. You can talk loud.
I can. I grew up with three brothers. The only way that the daughter. I'm going to try to do it. Can you hear me? Can I just thank you? Yay! You had to fight for the death. I did not bring PowerPoint either today. I really would just like to speak from the heart and say a bit about and engage you in a conversation. My mother's been dead now about 12 years, but she would often say to me, honey, can't you get a better job? And I would always respond by saying, I like what I do, I think I do it rather well. But she would respond in kind by saying, but it's very hard to brag about you at the club. That people are not that interested in talking about suicide, much more interested in talking about my brother who's a lawyer, another brother who is a university professor. So I can totally appreciate, it wasn't just Mom who used to say those things, that this is a relatively hard subject to talk about. But in our country, in the United States, one suicide occurs about every 15 minutes. And I think there's much that we can do to prevent those suicides. Not all, but many of them. So let me just give you a little bit of background. I'm a social worker. I'm flattered that you call me doctor, but I really am not. I'm a social worker by training. I was the founder of a youth suicide prevention program. Retired from there in 2011 and thought I was done. Thought my career was done, yay. I was going to rest and dig in the garden. And about 8 weeks after that, I met a woman by the name of Jennifer Stuber, who's faculty at the School of Social Work, who's up the street. And her husband, at age 40, put a gun to his mouth and killed himself. She's faculty, but not clinical faculty, teaches more policy and social justice in the School of Social Work, but was simply absolutely not prepared to have her husband die and leave her with two small children, Zoe, who was 2 at the time, and Jake, who was 4 and a half. So I met her shortly after, as I said, I retired, and she began this kind of journey of what can we do, how can we prevent other people from having this sort of tragedy in their family. And the picture that's up here is 3 years worth of work and many years of other activities. I want to talk to you about this. In the first year, Jen's idea was that we should make sure that all clinical social workers and mental health counselors and psychologists have training. And she was quite appalled that her husband didn't have very good care, or believed he didn't have very good care. And so we formed a coalition with another social worker who also happens to be a legislator, and went to Olympia and proceeded to get a bill passed that would require all of these licensed behavioral health specialists to have training. The sad part is that we don't get that in our social work education. So we graduate, we have these 3 letters after our names, different than your letters, and yet no preparation, but assumption that we would know what we were doing, but the truth is no classes, no training. So that was great. Jen was very excited. As a policy person, she was thrilled that she was able to change the legislation, and then I woke up in the middle of the night about a week later and went, holy crap. What have we done? Because it's one thing to pass a law, it's another thing to implement the law. And we probably can all relate to the Affordable Care Act and what's sort of the journey that Barack Obama has been on in this process of implementing. Right or wrong, however you believe about it, it's about the implementation. So with that, we realized that we didn't have any infrastructure in this state to offer training to 26,000 people. So we formed this organization called Forefront, Innovations in Suicide Prevention, which is now based at the School of Social Work. And I teach there, so come out of retirement, to teach graduate level social work students, but also to implement this organization. So I just, again, brought materials if you are interested in that. So we got really cocky, and the next year we thought, well, we passed one, we'll do another. And we helped pass legislation that would now impact school personnel. So social workers, psychologists, nurses, and what am I leaving out? School counselors, to get training on how to recognize youth in their schools who may be at risk for suicide, and where to sort of what to do with them, what to say. And every time we went to the Olympia to talk about these various bills, the conversation came up about why aren't you training, why aren't you requiring training for nurses as well as primary care physicians. So this past year, past month, Governor Inslee signed the bill that requires that all nurses and PCPs get training in how to recognize and how to manage suicide risk. So this was a monumental feat. It also keeps me awake at night worrying about what it is that we are trying to do with the very small staff that we have and the very large demand. So that's the bill. I actually wasn't there that day. Jen is the woman in the green dress with her 2 small children. And there was a huge crowd of people there because there had been taken a lot to get involved. People had to testify and come to Olympia and write their legislators to make that sort of thing happen. A lot of controversy around it. A lot of people not particularly excited about this. And yet it is our absolute belief that, and we see this in the data, that over half of those people who die by suicide have seen a primary care physician within a month of their deaths. I totally get that you're not PCPs, but people are also coming into care. Many people, as you well know, don't like you, don't like to have their mouths investigated, and even though they may be in pain. And so I really appreciate the opportunity to be here and to talk about this issue. But I saw a hand at the back. Is that?
I was just wondering, how did you push for the money for this? Because obviously, funds are always a huge problem. So how do you, for something that you're not going to maybe see in really become an investment?
Well, very good questions. I'm going to take a couple out of that. So one was the question of where the money come. And the money actually comes not from the state because it comes through requirements to get CEUs or CMEs or whatever kinds of. So as a licensed social worker, I must get a certain number of hours every so many years. In this case, it's now 2. And we didn't increase the number of hours. We simply asked that part of those hours be devoted to assessment and management. Same thing true in the CMA or CNE issue. So we lucked out in that way that there wasn't a huge cost because you're absolutely right. There is no money in the state government to do things that are perceived as kind of frilly but the other question you didn't necessarily say, but I'm going to turn it into a question. And one of the big issues is, does training make any difference? Do we really know? Does it change in terms of the number of persons who die or who attempt suicide? So, and the verdict is really out on that. It's not clear. We know that we can change knowledge and we can change attitudes about suicide, but we're still trying to understand more about how to have training that does something to change skills. So that's really a lot of our focus these days, is to not just talk about, which I will do in just a minute, talk about kind of the risk and protective factors and some of the data, but really, how do you talk to a patient? How do you recognize when someone may be at risk? So thank you for that. I think we're going to move ahead and try to see what difference we make, but we clearly know from the data that people are much more likely to see primary care than they're to see a mental health counselor. So even though we've passed these pieces of legislation, we need to get folks throughout to be more knowledgeable about what to look for. So let me just say a couple things about data. This is the data piece. In our country, about 38,000 suicides a year in our country, which is equal to the number of people who are dying by breast cancer. So I have a huge opinion about that, in that we have spent thousands and millions, actually, dollars on breast cancer awareness. I don't begrudge that. I think it's really important, and yet we don't spend nearly the amount of money on suicide prevention research that we do on breast cancer. So we have equal numbers almost of people in this country dying, and yet a real disproportionality around resources, particularly research dollars. The other thing I really need to say to you about that number, because I find it shocking, but on the other hand, it doesn't truly represent the entire picture. So in our state, in our county, there's a medical examiner for every county who makes the determination about cause of death. When it's not clear, and there are some times that suicides are clearly not clear, then that gets counted either as undetermined or accident or something else. Those, I guess, the 2 categories. And so I'm absolutely convinced there are more people dying by suicide than we're actually counting in our statistics. The other thing that's very interesting about the state of Washington is that we do not collect data related to emergency room admissions. So we only know, so a person who comes, who has overdosed, cut themselves, talking about suicide, does not get counted in our state statistics unless they spend a night in the bed. And there are many, 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 many people who are admitted to EDs and never admitted into the hospital. So the numbers are difficult for me to comprehend, and yet they're truly not the entire picture of what we are talking about. I just realized that I should have said in my intro, I was in between jobs, I think now about 15 or 20 years ago, and I took on the job as the interim executive director at the Yesler Terrace Health Clinic. And I had the unfortunate responsibility of shutting down that agency because it was way out of financial compliance and things were a mess. But as I'm looking at you as dentists, I'm thinking about the horrible thing that I did, and I'm confessing, I guess. I just closed the doors one day, and people were in the midst of their dental procedures, and it was like chaos. And yet there was absolutely, at the time, felt like there was no alternative and no place to refer those patients. So I don't know what, I'm feeling terrible about it. But it was one of those days, the board said, you're closing, the door's closed. People knocked on the door and said, but my dentures were just being made, where are they, kind of things. And I'm going, ah! So, but it speaks to part of your larger issue here. I also spent a number of years working at Pioneer Square Clinic. That time I didn't close it down. I was actually the mental health clinician, but worked many years, both uphill at Harborview and down the hill at Pioneer Square, working with folks who were in physical health crisis as well as mental health crisis. So I do really appreciate what you're doing and the population you're serving, and your desire and willingness to understand this issue more. So just in terms of data, I also want to, and you mentioned it a bit in your intro, in this country about 22 veterans die by suicide every day. Every day in our country. And yet that does not reflect data from California or Texas. They don't include data in that. And there are many, many, many veterans who live in California and Texas. So we know that we have a huge population of veterans who are dying and or at risk for dying by suicide. Men are at highest risk regardless, men. So play with me. Why do you think men are more likely to kill themselves than women? Yeah?
They use more violent means.
So lethal means one of the absolute reasons. Yep. Firearms. Others?
Doesn't take the responsibility. Men don't generally take responsibility for the kids, so it's just their decision.
So part of it is that there may be fathers, but they don't have that same kind of connection to or find value in the kids in the same way that their mother's role does. Yeah.
Just like they're not as willing to seek help.
Huge. Not as willing to seek help and to talk about what's hurting, either physically or emotionally. So men at much higher risk, and it was for a long time that our seniors, I don't think of them seniors because I'm now 65, but seniors, people 65 and older, at highest risk for suicide, particularly men, and that's actually changed. So we're looking at men 40 to 59 years of age, highest risk group. Using lethal means, primarily firearms, as a way of ending their lives. Second leading cause or method of death, I should say, suffocation or hanging. So this is kind of the gory part of the program. Women much more likely to seek help, much more likely to be hospitalized as a result of suicide ideation, and much more likely to use less lethal means. But many, many, many people do not ever come in for service. So what's lovely about what you're thinking about here is that you may be working on someone's teeth. And the kind of pain that's associated with that, or the discomfort associated with that, or simply that they feel the opportunity to talk to you really is important to me as we think about how to prevent these from happening. In terms of depression, a very significant underlying cause for suicide, not 100%, but a large majority of those who have died by suicide, we believe, were either acutely or chronically depressed. We also know that any of our personality disorders, as well as substance abuse, huge issues related to risk for suicide. And you combine those and you just increase the likelihood of risk. So just in terms of data, is that a hand? Yeah.
Yeah, I have a quick question.
Yeah.
So you said the statistic about veterans.
Yeah.
I'm curious if you have an idea of like of the homeless population in general, if that's.
You know, the data that we get is pretty mediocre from a DELF report, sorry to say. So sometimes we know that it will say no current address, but we don't, that's not well organized, and so I'm sorry to say I don't have it because it's not well orchestrated. I wish and there was not very good advocates, frankly, for the homeless, particularly around this issue. But having seen as many homeless, particularly men, in the downtown Seattle area when I worked at Pioneer Square Clinic, absolutely, homelessness can only be a risk factor for suicide. Not having a place to live, having that insecurity about food and shelter, I think are really important factors. And many of our downtown, at least in Seattle folks, are disenfranchised or estranged from families, so there isn't that sense of support that we typically look for and we ask for. The other thing that I'm sure you're already addressing and thinking about, but the amount of heroin and opiate overdoses that we're seeing these days that are being counted as overdoses, but are they suicides, and lots of questions about that. And many folks getting those prescribed pain medications from dentists and from doctors, and how do we then help them in terms of staying safe and not using those as a way of ending their lives. So we're very concerned about opiate issue as well as the firearm issue. Please.
I heard that, I'm sorry, I can't think of the antagonist for opiates, but.
Narcan?
Yeah.
Yeah.
Are you an advocate for getting that?
Yes, we are an advocate for that. I just think we have to do whatever we can to make those kinds of alternatives available. So is it a lockbox for a gun? Is it taking out the firing chamber? Is it having Narcan available? I personally would not, but I would want to have that resource available for those who are working face-to-face directly with folks who are using and abusing it. Yeah. And there's very good evidence to suggest that Narcan can make a lot of difference. There's also been a change in terms of the Good Samaritan-ish law related to, I'm taking my friend, he's used this, I don't want to be in trouble, I don't want him to be in trouble, and there's now protection, of course, around that, so people are more likely to seek help for themselves or their friends. So, where do I want to go with here? So let's just talk about, so depression, I'm sure how does it show up in men? What does depression look like in men? Is it different in women?
Anger.
Big time. Lots of irritability or anger or just being righteously pissed off. Lots of it. And many times we get confused about it because it doesn't look like the advertisements that you see on TV for antidepressants. Many of our depressed men do not look longingly and sadly out into the distance. Lots of anger. Other ways that men show up as depressed. Not taking care of themselves or their mouths or their physical health. Absolutely, absolutely. So, I think that's also true for women. But women are more likely again to seek help, more likely to ask for help, maybe coming into a clinic. Women are dragging their men in, so men don't always come by themselves. But we're going to primarily look for this irritability, this lack of self-care, and substance abuse, without a doubt. We're going to see those issues as people are dealing with levels of despair. Many, many times we're also seeing men at risk who are unemployed, as well as not in a relationship, whether that's same-sex or opposite sex, but that sense of being alone and not being in support or around others. So again, if I were in your shoes, working on a patient, I would love for you to be a single guy you might have a history of substance abuse, having a history of diabetes. I think that's fascinating that you discovered that a third of those patients. So what's that about? How in compliance are they with their diabetic or nutrition regime? I think are issues that are important to look at. What's their perceived value of their life? So there are kind of things that, there are things that I would encourage you to be able to say to a patient. I recognize that you're not the mental health counselor, but there are powerful things you can say, like, I'm concerned about you. I'm concerned about what's going on. I'm concerned about what you're telling me or trying to tell me. I'm concerned about what I've read in the record. Here's what happens for many of us. If we get anxious or we feel like it's none of our business to butt in, and so number one, we don't say anything, or we say something very quickly without really listening for the answer. You're okay, right? So who's going to answer, no, I'm not? Typically, sure, right, I'm fine. So mostly what I want, first of all, to be very clear that one of the major steps here is to simply show these patients that you care about them, more than just their teeth perhaps, but what's going on for them, how are they, what are some, and I know you don't have a lot of time, and I always hate it when my dental hygienist tries to engage in an interesting conversation with my mouth full of things, so it's like, really? Are you that interested? But people say things at reception, at the end of a visit. There are times and opportunities, even when your tools are not necessarily in their mouths. One of the habits that I think I want to try to break is one that I particularly at this initial conversation with someone who I think may be at risk of suicide, is to simply slow down and ask one question. And hopefully that question doesn't start with why. If I say to you, and you don't really have to answer this, why are you sitting here? You have to like I picked you out of this whole group, and it means that you have to justify your answer. Why questions push people into corners, whether you're at risk for suicide or not. So simply trying to avoid, why are you looking so sad? Why aren't you taking care of yourself? Why haven't you flossed? Requires some defense or justification, and that truly is puts people in a corner. The other thing that we tend to do, particularly when we're nervous or uncomfortable around the subject or the person, is we ask multiple questions without waiting for the answer. So my mother's favorite kind of, long time ago, but my mother's favorite response when I'd come home from school is, "Hi honey, how was your day at school? Do you have any homework?" And embedded in there, of course, are two benign questions. But the truth is that when someone is feeling vulnerable, maybe even coming to the dentist in itself feeling vulnerable, and then we ask multiple questions without waiting for a response, kind of, I think, can sort of send the message that we're really not that interested in the response to that question. So I would encourage you to slow down, make one statement. Typically, I will say something like, "Tell me about what's going on," as opposed to "why." And then truly, as much as you can do, waiting for the answer. And some of our patients, yours and mine, take a long time for that response to come forward out of their mouths. Sometimes they never respond, but if we don't give them room, it'll never have a chance to respond. Then, of course, what I would want you to be able to do is to ask directly about suicide. And this is probably the hardest thing that I ask people to do when I'm teaching them. But the reality is, we don't know unless we ask. So why don't patients tell us they're suicidal? Many don't. They don't march into my office and say, "Oh, Sue, I'm thinking about ending my life." How come? Stigma. What was the other one?
I just said it's awkward.
It's awkward.
Same.
Yeah. So sometimes, and they worry. What are you going to do? What are you going to say? Please.
And if they're serious about it, they don't want to be stopped.
Right. And so they may say, "I don't want to tell you because you'll do something. You'll call 911, you'll strap me to a gurney, you'll make me take medicine I don't like or I've taken before, and so I'm not talking to you." But the most important thing is to be able to ask calmly and directly and clearly. So if I were to say to a patient, "Are you thinking about doing something stupid?" Not that clear and pretty judgmental, particularly painful with adolescents who do not want to be accused or believe they're doing anything stupid. And if you're not clear, are you thinking about not being here? Are we talking about, this seminar? Are we talking about Seattle? Are we talking about this earth? What are we talking about? So it's got to be clear. Are you thinking about ending your life? Are you thinking about suicide? Are you thinking about dying? Whatever way that you choose to do that. Years ago when I was at social work school, what we were taught was, are you thinking about harming yourself? And yet the field has really progressed, and so lots of harming behavior happens. There are people who are self-injuring, which is different behavior than suicide, and we want to be very clear. So what I always say is, perfectly okay to ask about harm. It's just not enough. You got to keep asking that clear and direct question. And it's pretty amazing how many times people actually answer truthfully. They want to be asked. Suicide is, in my opinion, not about wanting to die, it's about wanting to end pain. That may be physical pain, more likely it's about psychological pain. And they want, and I think people truly want some relief from that pain, and those who are suicidal are at that point where they don't see any other options. They talk about feeling like they're a burden. They talk about things would be better off if I were here. Things would be easier for my family. I wouldn't have to worry about where I sleep every night. The pain in my mouth would be gone. Whatever that is, but they think it's a solution. They really think it is the fix. I can tell you, for over the years that I have worked with families who had lost someone to suicide, that's not that's not what they want. They want that person to stay alive. There's a brochure here that may or not, neither of these may be relevant for you, but feel free to take them. But one of the things that the organization Forefront has really tried to do is to support survivors. And I want to just say a bit about the loss to suicide. The grief associated with suicide loss, to me, is very different than any other. So when my father, at 84 years of age, was diagnosed with colon cancer, I could see him getting smaller in the bed. I knew those days were coming. It didn't make it any less sad for me, but the reality was I had some preparation. I can understand it that way. We don't have that same kind of preparation in a car accident, but what we do have in a car accident is this issue about being able to make sense out of it by finding some external cause for that. The sun came out, blinded me, there was ice on the road, they fell asleep. There's an external explanation. And I think the curse, the challenge, the complexity about suicide really has to do with how does a bereaved family member figure out how to make sense out of something that they didn't expect was going to happen, and who do they point the finger to? Who do they blame this on? And blame sort of has a very negative sort of connotation there, but that's what we do in grief. We try to make sense out of it and really look at what can we do to prevent that sort of thing from happening again. So you may not be dealing with people who are suicidal, but you might be dealing with someone in the aftermath of suicide, or you might be doing both. Remember, with 38,000 people a year dying by suicide, the ripple effect is enormous when you look at the number of people who are impacted by those deaths. One of the hugest, that's not even a word, one of the biggest challenges I think in this work truly is to have people feel like they're not responsible, that it wasn't their fault. And there's a lot of personal responsibility. You know, I should have come home sooner if only we hadn't had a fight, if I'd gotten him help. And I can tell you, just working as closely as I do with Jen, whose husband again died by suicide, I think a lot of her motivation for this work is about trying to make sense out of his death and making a difference in the world, that sort of his legacy. So asking the question, being clear, and allowing that to be asked and answered. And then the third thing that you would do is to get help. So the person has said yes, they're in your dental office, and then what the heck do you do with them? Oh my God. Not everybody needs to go to the ER. I try to keep people out of the ER if I can. If you probably spent time in the ER, it's not the ideal place to be. And given our mental health system, the truth is that many folks don't get hospitalized as a result of suicide ideation or suicidal behavior. So if we can avoid hospitalization and avoid the ER, that's the greatest. I'm much more likely to be doing some kind of safety plan. Don't expect you to necessarily do that. But you should know what kind of resources there are. The one slide I could have made for you, I did not. So there is a national hotline, a telephone line. It's here in Seattle. It's answered by the Crisis Clinic, which has long time been in business and a big hotline. But the telephone number is 800-273-8255. 800-723-8255. Wherever you are in this country, if you access that phone number or give it to a patient, Somebody answers that phone, most typically to the closest certified center from where they are calling, and help is available 24 hours a day. Someone will answer that phone and provide listening support and resources and hopefully some hope and connection. So 800-273-8255 is the National Suicide Prevention Lifeline, and it is sort of that resource that we call upon. You may end up calling 911, but just to understand that when the police come, they do have the possibility of they can't transport, so they'll call an ambulance. It's very likely that that person will be in handcuffs for a period of time. It's not the ideal way to go to hospital to get care. So if we can avoid that, I would definitely encourage you to do that. So really for me, the takeaways, my hope for you is that there would be this opportunity to appreciate it is a big issue, whether that's about homelessness or not. It's a huge issue in our country. It's not well funded, it's not well researched, and we have much work to do in this regard. But I think as individuals, whether that's, and sometimes when I teach this class, and I'm teaching it, when I think about this, it's not just when we have our professional hats on. Some of you have had the experience yourselves, or you've had family members who've had thoughts about suicide, or made suicide attempts, or died by suicide. This becomes, frankly, can be a very personal issue as well as a professional issue. So prior to my father being diagnosed with colon cancer, he was a stubborn 84-year-old man who refused to go to the doctor when he was experiencing significant, what I would say was bronchitis, though I'm not a nurse, a social worker, coughing, couldn't get his breath. And one morning he coughed so hard that his vertebrae moved into his spinal column and left him paralyzed. And he went to Swedish Hospital, and I came immediately to see him. And he was very confused about what was the quality of his life. He also, most important thing, my mother had died then, the most important thing was he going to be able to drive? That whole independence and not being a burden and not being able to be independent and mobile. And it was very clear that he wasn't going to, he was going to be in a chair. And he said to me, "Honey, will you help me die?" And I freaked out. It's one thing to have my social work hat on, it's another thing to have my daughter hat on. And I remember just sort of looking at him. And I didn't say anything much that day, and we didn't talk a great deal about it. And the next day I came back and I said, I really have to talk to you about this. And I can't do anything for you in the hospital now, but if you're discharged or when you're discharged, you and I need to have that conversation. He said, "Oh, no. That was yesterday. Today I'm feeling much better, and it wouldn't look good if the father of the queen of suicide prevention killed himself, so I'm not going to do that." So, and I like that story for many reasons. One is there were definitely risk factors. Being injured, feeling a burden to others. I could see that, and being alone and feeling like he just didn't want to bother others. And at the same time, and what we always listen for in this work is sort of, what are those protective factors? Remember the olden days when there were teeter-totters on the playground? They don't exist anymore for liability and all sorts. But think about those judicial scales that we see. But there are risk factors on one side, and what we always want to be listening to and thinking about is, what are those protective factors? What balances those reasons that people have for dying? If you think of the number of people who are dealing with pain or depression or a multitude of issues, that teeter-totter is often down here. But there's something, and I think it's true about homeless folks, there's something about resilience in the homeless population that I admire. I don't understand it, but I definitely admire that. How do you persevere? And so on that side, in my father's case, I think was guilt, or a sense of responsibility, or a good sense of humor. But there can be also those protective factors about, just as we see in so many of our homeless folks, that sense of resilience. That they've dealt with a lot, and yet they persevere. So as you are dealing with patients, think about not only the sort of reasons for dying, but what might be those reasons for living. And you may be it. That sense of that somebody cares about me, somebody's checking on me, somebody's asking me questions that they seem to be interested in. I'm happy to take questions. I know that some of you have to begin to move on to other things, but if there are questions, I'm happy to take them. Please.
What resources are available for children who have seen their parents commit suicide?
What resources are there for kids whose parents, so there are different, if you're in Seattle, there's a place called the Healing Center, there are the crisis clinic, there are support groups, there are individual therapists. I mean, they're really, and kids really need to have a conversation with others. So actually I'm going this afternoon to my job at the Healing Center, where I do support for kids and their parents around this issue of suicide. So Matt, the little boy in the blue there, in group, because he's dealing with what it's like to lose a daddy. And when you're 7 or 8 or 9 and someone says, "Where's your dad?" What do you say? He's dead? Well, how did he die? Oh, he put a gun in his mouth. I mean, there's all those kinds of things that kids need to have a sense that they're not the only one, and how do I help them answer some of those tough questions. But I think it's life-changing, without a doubt. What I always say is that suicide, there's no getting back to normal. What families have to do, what kids have to do in the aftermath of a suicide is create a new normal, whatever that looks like. Anything else? Then I'm going to stop.
Thank you so much.